Okay, in our video series of pulmonology lectures, in this video we are going to talk about acute respiratory distress syndrome, ARDS. We are going to talk about the clinical presentation, the diagnosis and treatment of ARDS in detail. We have a case here. A 32-year-old lady was admitted to your ward with the complaints of pancreatitis and she was treated for pancreatitis. She was doing well, but on the 6th day of admission, suddenly she developed shortness of breath. She was not maintaining saturation. She was doing well. Her yesterday X-ray was totally normal. But today, all of a sudden, she became short of breath and she is dropping saturation. When you ordered the chest X-ray, you received a chest X-ray like this, which is showing diffuse infiltrate, a complete whiteout. This patient was shifted to ICU and was intubated and diagnosed as a case of ARDS, acute respiratory distress syndrome. Why did this patient develop sudden respiratory distress? Today we are going to talk about it in detail. Acute respiratory distress is a clinical syndrome of acute respiratory failure characterized by hypoxemia and by lateral pulmonary infiltrates that cannot be accounted for, that cannot be explained by heart failure or fluid overload. The patient was not having any heart failure, the patient was not in fluid overload, the patient was doing well, but all of a sudden she developed severe sudden onset hypoxemia. The patient was not maintaining saturation and patient developed bilateral pulmonary infiltrates, sudden onset respiratory failure with bilateral pulmonary infiltrates that cannot be explained by heart failure or fluid overload. That is a classical picture of ARDS. Now you would be thinking that when the patient is not having any heart failure, patient is not in fluid overload, then why is this patient developing such infiltrates in the chest all of a sudden? Basically, our patient was having pancreatitis. Whenever the patient is in sepsis or any condition like pancreatitis where there is inflammation already going on in the body, that inflammation can spread to the lungs. And when that inflammation affects the lungs, when that inflammation involves the lungs, that can cause increase in the capillary permeability and leakage of fluid in the lungs. That is a very dangerous complication of sepsis. That is a very dangerous complication of pancreatitis, where the inflammation can spread to the lungs and cause leakage of fluid in the lungs, resulting in acute respiratory distress syndrome. What are the causes of acute respiratory distress syndrome? Remember, sepsis is the most common cause, because in sepsis there is diffuse body inflammation going on. The body is fighting with bacteria, and during that fight it is producing lots and lots of cytokines and inflammatory mediators, and those inflammatory mediators, those cytokines actually cause increase in the capillary permeability in the lungs, and when it causes increase in the capillary permeability in the lungs, it causes leakage of fluid into the lungs. We are also going to discuss pathophysiology in detail after this. Acute pancreatitis is also an important cause. Trauma can result in acute respiratory distress syndrome. Shock, massive transfusion can result in acute respiratory distress syndrome. Recreational drug overdose like cocaine overdose can result in acute respiratory distress syndrome. But remember, in MCQ, if they ask you what is the most common cause, remember sepsis is the most common cause of acute respiratory distress syndrome in patients. Now, how does acute respiratory distress syndrome occur? Whenever there is tissue damage going on in the body, like in pancreatitis where the pancreas is getting digested by its own enzymes, or when the patient is in sepsis, sepsis may be due to a severe UTI where the body is fighting bacteria, the body is having severe inflammation, fighting an infection. During that period, the immune response is active. There are interleukins present in the body. The body secretes inflammatory mediators IL-1 to fight off that infection, to fight off that tissue damage. But that inflammation spreads to and migrates into the alveoli. That inflammation migrates to the lungs. That results in migration of neutrophils in the lungs, and neutrophils carry reactive oxygen species. It contains oxidizing agents, proteases, enzymes. If these neutrophils mistakenly migrate to the alveoli, they will damage the alveoli. If they damage the alveoli, that will result in sudden onset injury to alveolar capillaries and endothelial cells. The alveolar capillaries will be damaged, endothelial cells will be damaged, and that barrier that we have between the lung walls and the capillary wall, that barrier is broken down, and all the fluid starts leaking in and accumulating in the lungs, resulting in diffuse alveolar damage, and acute respiratory distress syndrome. So basically, body is fighting off an infection, or body is having inflammation, and that inflammation suddenly spreads and involves the lungs. That is the basic pathophysiology. If you know the pathophysiology, it's very easy for you to manage these patients. It's very easy for you to diagnose these patients. Now this is a picture showing normal alveolus where there are type 1 cells that are forming the lung walls, and type 2 cells are the cells that produce surfactant. And this is the capillary that is going on, and this is the capillary wall, the endothelium of the capillary wall. Now what happens in acute respiratory distress syndrome is that this barrier of the alveolus and this wall of the capillary is damaged by these inflammatory markers, damaged by these neutrophils, damaged by this immune response that results in leakage of the fluid from the capillaries into the alveoli. Now in this picture you can see that the capillary permeability has increased, the gaps between the cells in the capillary have increased, and within these gaps neutrophils are migrating outside and they are producing proteases, and those proteases are damaging the wall of the alveolus, and whenever they damage the wall of alveolus, fluid starts accumulating, protein rich edema fluid is accumulating, and that the process of inflammation begins. Lungs is a very sensitive tissue, and once inflammation begins in the lungs, it spreads immediately throughout the lung. Therefore you see a complete whiteout on the x-ray. Therefore you see all the fluid accumulated in the x-ray. When you auscultate these patients' chest, you will hear diffuse crackles in their chest. These patients will not be maintaining saturation, and this will all happen very suddenly in these patients. Now what happens is that there is an exudative phase of acute respiratory distress syndrome. In exudative phase, excess fluid accumulates in the lung interstitium that results in pulmonary edema. This is an alveolus, and in alveolus fluid starts to accumulate, resulting in pulmonary edema, and this pulmonary edema is non-cardiogenic. Patient is not having any heart failure, but still he is developing this type of pulmonary edema. So this is acute respiratory distress syndrome. And then there is hyaline membrane formation phase. In this hyaline membrane formation phase, there is exudation of protein rich fluid. The inflammation that is going on in the body, that is producing lots of antibodies, lots of proteins to fight off that infection. But those proteins, those inflammatory markers are moving and attacking the lungs now, and that results in exudation of protein rich fluid in the alveolar space. That results in hyaline membrane formation. If this is an alveolus, look at the wall. The walls get thick because of all the inflammation that is going on in the wall due to the exudation of protein rich inflammatory cells into the alveolar wall. So this is how exudative phase and hyaline membrane formation takes place. And now can you even imagine that if the alveoli is filled with fluid and the alveoli has thick exudates in its walls, how can oxygen pass through these alveoli? Therefore these patients will be hypoxic, these patients will be having low oxygen level, they will be cyanosed. This inflammatory response will also damage type 2 respiratory cells, and whenever type 2 respiratory cells are damaged, there is surfactant deficiency, and whenever there is surfactant deficiency, surfactant keeps the alveoli open. Whenever there is surfactant deficiency, these alveoli will collapse, and there will be alveolar collapse in these patients. If you understand the pathophysiology, it's very easy for you to understand the whole concept of the disease. You can easily understand the clinical symptoms that the patient will be having. You can easily imagine how will you treat that patient, because all you have to do in this treatment is to reverse this pathophysiology. So it's very important, whenever you're learning medicine, it's very important that you know the pathophysiologies of the diseases as well. Now you can easily imagine what can be the clinical presentation of these patients. These patients will develop sudden shortness of breath. These patients will be totally okay one day back, but the next day these patients will develop a severe shortness of breath, dyspnea, tachypnea, tachycardia, cyanosis and diffuse crackles. Remember, cyanosis and diffuse crackles, sudden onset. This is a classical picture of acute respiratory distress syndrome. Fever, cough, chest pain can also occur in these patients. Now, how do you diagnose these patients? The very important and the basic thing that you have to do is, the first thing that you have to do is chest x-ray. Whenever a patient gets sudden shortness of breath and you listen to the chest and there are crackles in the chest, it's very important that you do the chest x-ray. On the chest x-ray, you will see a white lung. If you see a diffuse white lung like this sudden onset diffuse white lung can only be due to acute respiratory distress syndrome. This is another picture showing acute white lung seen in respiratory distress syndrome. This is all fluid that has accumulated in the lung. This is all the inflammation that has increased the capillary permeability and leakage of fluid into the lungs. Now, the next very important thing in these patients is that you perform arterial blood gases, ABGs. You prick the artery and you take the arterial sample and you send it for the blood gases. And remember, whenever you take the arterial sample in these patients, you must note down that whether the patient is on oxygen or without oxygen. If the patient is on room air, you have to note it down, or if the patient is on oxygen, then you have to note down that how much percentage of oxygen is being given to that patient. Now I'll tell you why is it important. When you receive the ABG results, the very important thing that you will have to see is partial pressure of oxygen, because partial pressure of oxygen will be low in these patients because these patients are hypoxemic. Now, what you have to do is that you have to perform a certain calculation where you divide partial pressure of arterial oxygen, partial pressure of oxygen that you got in your ABG test, you divide it by a fraction of inspired oxygen. Now, how do you calculate fraction of inspired oxygen? Now, when you are sending ABGs and you noted down that patient is not on oxygen mask, patient is not on oxygen, and patient is breathing room air contains 21% oxygen. Now, let's say we got the ABG result and partial pressure of oxygen on ABGs was 60 mm of Hg was the partial pressure of arterial oxygen that you got on the ABG result. And patient was not on oxygen mask that time when you were taking the ABGs. Patient was breathing room air, and room air contains 21% of the oxygen. What you do is that you convert 21% into decimal, that is 0.21, and you divide 60 mm of Hg by 0.21. Remember to keep the room fraction of inspired oxygen in decimal, and you get a certain result like 285 mm of Hg. If the result is less than or equal to 300, it indicates that the patient is in acute respiratory distress syndrome. This is very important to calculate this because this will show you the severity of ARDS. Now, let's say if the patient was on oxygen mask, patient was already on oxygen and you were giving, let's say, 40% oxygen to that patient, and you took the ABGs. You have noted down that when I was taking the ABGs, the patient was on 40% oxygen. Now, when you receive the result of ABGs in this patient, you see that partial pressure of oxygen is 80 mm of Hg. The arterial oxygen is 80 mm of Hg in the ABG result. And patient was on 40% oxygen mask. Patient was already on supplemental oxygen. Now you have to note it down in the decimals in the denominator. You write it as 0.40. And when you divide this, you get a result of 200 mm of Hg. It means that the patient is maintaining this saturation on supplemental oxygen. And this ratio indicates that this ratio is less than 300 and this patient is in acute respiratory distress syndrome. Why is this fraction important? This fraction is important because this will tell you the severity of ARDS. If the patient is having this ratio from 201 to 300 mm of Hg, then it is mild ARDS. If the ratio is from 101 to 200 mm of Hg, it is moderate ARDS. If it is less than or equal to 100, then it is severe acute respiratory distress syndrome. We will manage these patients according to this. Additional investigations that you have to do in these patients. Remember, ARDS is a diagnosis of exclusion. You have to exclude all other important causes. When you are unable to find other causes that explain this sudden acute respiratory distress syndrome, only then we make the diagnosis of ARDS. You have to rule out heart failure. In old patients, it becomes very difficult because those patients are already having heart failure and they get sudden onset shortness of breath, and it becomes very difficult for you to differentiate that whether this respiratory distress is due to heart failure exacerbation or it is an acute respiratory distress syndrome. In such patients, you must always do echocardiography. You look at the status of the heart, you screen that patient for MI, you do ECG, you perform cardiac troponin levels, you perform brain natriuretic peptide. In heart failure patient, if the respiratory distress is due to heart failure, the BNP levels will be elevated. If the acute respiratory distress is not due to heart failure, then BNP levels will be normal. I have talked about the importance of BNP in detail in my video on acute decompensation of heart failure. You can check out that video in the cardiology section. So you always rule out other important causes of acute respiratory distress in these patients and then make the diagnosis, because remember, acute respiratory distress syndrome is a diagnosis of exclusion. There is a certain criteria that is used for the diagnosis of acute respiratory distress syndrome that is called as Berlin criteria, and all of these 4 conditions must be met for the diagnosis of acute respiratory distress syndrome. It should be acute onset. Within less than a week, patient developed this sudden onset shortness of breath. There should be bilateral opacities on the chest X-ray. Diffuse bilateral opacities should be there. Hypoxemia should be there, and you calculate this ratio, and this ratio should be less than 300 mm of Hg, ratio of partial pressure of arterial oxygen by a fraction of inspired oxygen. And the respiratory failure cannot be accounted for, and this respiratory failure cannot be explained by heart failure or any condition that is causing fluid overload. So this Berlin criteria must be met whenever you diagnose a patient with acute respiratory distress syndrome. It can be simply remembered with the mnemonic ARDS, A for abnormal X-ray, R for respiratory failure within a week, D for decreased partial pressure of arterial oxygen to FiO2 ratio, S for should always exclude CHF and fluid overload in these patients. So this is a mnemonic that you can use to remember the Berlin criteria. Now, if a patient is having heart failure and that heart failure patient develops sudden onset shortness of breath, remember, it becomes in clinical practice really difficult to differentiate that whether this is acute respiratory distress syndrome or heart failure. There can sometimes be an overlap between both presentations. So pulmonary artery catheter is a technique where they pass a catheter in the pulmonary artery and they detect the pressures of the left atrium. If the pulmonary capillary artery pressures are high, it means that there is increased load on the left side of the heart. And if you find high pulmonary capillary wedge pressures, then it indicates that the heart is in overload and heart cannot pump the blood out efficiently. The heart is weak. Therefore, there is blood accumulating in the left artery, resulting in high pulmonary capillary wedge pressures. If high pulmonary capillary wedge pressure is found, it indicates that heart is weak and is unable to pump the blood efficiently ahead to the body. Therefore, heart failure is likely. If pulmonary artery catheter pressure is low, it indicates that left heart is totally fine and it is effectively pumping the blood to the body. And it is not the heart that is causing this pulmonary edema. It is the inflammation of the lungs due to the inflammatory response that is causing ARDS. So pulmonary capillary wedge pressure will be low or normal in ARDS. Other findings that are supportive of ARDS rather than congestive heart failure decompensation, ARDS will show peripheral opacities in the lungs, while congestive heart failure will show bat wing sign where there will be opacity near the hilar region. Now this is a picture. If you see, the opacities are near the hilar region, that is called as a bat wing sign, where above and below you can see the lungs are black, but in the hilar region in the middle there are opacities. So this favors the diagnosis of acute heart decompensation, acute heart failure decompensation rather than ARDS. Other than that, in ARDS there might not be pleural effusion. If the pleural effusion is present, it indicates that might be heart failure decompensation. In ARDS you won't be able to find cardiomegaly. In congestive heart failure, cardiomegaly will be present. Now coming to the management and treatment of acute respiratory distress syndrome. Remember, whenever you suspect that a patient is developing acute respiratory distress syndrome, always consult ICU immediately. Write a call to ICU and tell them that we have a patient of acute respiratory distress syndrome, and very soon these patients are going to need ventilatory support. These patients of acute respiratory distress syndrome deteriorate very rapidly and they will need ventilatory support after some time. And the second most important thing is you address the hypoxemia. These patients are hypoxic, these patients are cyanosed, they are not maintaining saturation. And addressing and treating hypoxia is very important. As soon as you suspect ARDS, treat these patients for hypoxemia. Remember, hypoxia causes pulmonary vasoconstriction, and the more hypoxia the patient is having, the more patient will be having pulmonary vasoconstriction, and it will further cause worsening of the acute respiratory distress syndrome. It's like a vicious cycle. The patient gets further worsening. How do you address hypoxemia? If the patient is having mild acute respiratory distress syndrome, then you give 100% oxygen, full high flow oxygen via NRM mask. You give maximum oxygen to these patients. This is a picture showing NRM mask, and you immediately start high flow 100% oxygen to these patients, and you write a call to ICU. If the patient is having severe acute respiratory distress syndrome, this patient needs invasive management, where you do endotracheal intubation, where you pass a tube down the trachea and you connect that patient to a ventilator, where the ventilator starts in providing breath to the patient. If you want to learn about ventilator, I have a full video on ventilator. Please make sure to check out that video. And then you apply lung protective ventilation through ventilator. What is lung protective ventilation? Now we are going to discuss that. When a patient has been connected to the ventilator, in the patients with ARDS, you do lung protective ventilation, where you give low tidal volumes, low plateau pressures to prevent barotrauma, because their lungs are inflamed and they cannot bear the volumes, they cannot bear high pressure. So you keep them on low tidal volumes, you keep them on low plateau pressures. You do prone positioning in these patients. Prone positioning is very important. When a patient is lying down supine, when the patient is lying down straight, what happens is that heart is lying anteriorly in the chest, and maximum of the alveoli are present at the back of the lungs. At the back side of the lungs, the maximum alveoli are present. Now this heart will put pressure on those back of the alveoli, and these alveoli will be collapsed. When the patient lies down supine, the heart lies downward and these alveoli are open, so there is no pressure on these alveoli. That's how prone positioning helps. Another cause is that whenever patient is lying supine, the abdominal organs also compress the diaphragm, and they compress the back side of the lungs that contain maximum of the alveoli. When the patient lies down supine, the pressure is on the anterior part of the lungs, and the area where there are maximum alveoli, the pressure is low and the alveoli can easily open up. Therefore, there is decreased compressive effects of abdominal organs when the patient is lying down in a prone position. You should keep the patient in prone position for 12 to 16 hours per day. So you contact the ICU. If the patient is having mild hypoxemia, you start on NRM mask, high flow oxygen. If the patient is having severe distress, you start the patient on ventilator, and you do lung protective ventilation, you do prone positioning in the patient, and you also do lung recruitment maneuvers. In the lung recruitment maneuvers, you make sure you do certain ventilator settings to make sure that maximum of the alveoli in the lungs are opened. And we are not going to go into much detail of the lung recruitment maneuvers because they come in the ventilator settings. You identify and treat the cause. Remember, whether it is pancreatitis, whether it is sepsis, whether it is pneumonia, whether it is trauma, remember you have to treat the cause. If you don't treat the underlying cause, the patient will not improve. You do conservative fluid management in these patients. You give less fluid to these patients, because if you give normal amount or more amount of fluid to these patients, it can go into lungs and accumulate there. You consider furosemide in these patients for 20 to 40 mg IV BD, and you can titrate to wash the fluid out from the lungs that has already accumulated. You give venous thromboembolism prophylaxis if they are on ventilator. You optimize their nutrition, and you consider stress ulcer prophylaxis with PPIs. Corticosteroids have off-label use in patients with ARDS, and they are used in patients with early ARDS, and they can reduce inflammation, increase oxygenation in these patients. IV methylprednisolone is given 1 mg per kg IV OD, and budesonide is given in the nebulizer form 1 mg per 2 ml per inhalation every 12 hours for 15 minutes. So inhalers, budesonide is given via inhalers, nebulizations. In patients with severe acute respiratory distress syndrome with persistent hypoxia, despite doing all these measures that I have mentioned, rescue therapy can be performed in these patients. Rescue therapy involves giving inhaled vasodilators like nitric oxides or prostacyclines to these patients, because their vessels are vasoconstricted in response to hypoxia, and they are not providing enough blood for the gaseous exchange. You give nitric oxide, prostacycline, so that there is more blood supply to the lungs, so that some oxygenation can take place. ECMO is the last stop, and it is basically an artificial lung membrane, and just like an artificial heart, it's an artificial lung membrane that can oxygenate the blood and provide it to the body. So that is a rescue therapy that is done in patients with severe acute respiratory distress syndrome. Prognosis: most of the patients can improve if early measures are taken, if early oxygenation and hypoxemia treatment is done and patients are shifted to ICU. They improve in 1 to 3 weeks with complete recovery. And in some patients, there can be residual fibrosis because inflammatory response can be so severe in these patients that can result in permanent lung damage, resulting in pulmonary fibrosis. If the patient develops multi-organ failure, then mortality can be 30 to 50% in these patients, and it may be even higher in patients who are in developing countries. If you liked my video, please make sure to click the subscribe button and support us on Instagram, Buy Me a Coffee. Make sure to check out my other lectures on neurology lectures, emergency medicine lectures, pulmonology lectures, cardiology lectures. I have a whole playlist of these lectures on my channel. We talked about what is ARDS. We talked about sepsis being the most common cause. How does immune response due to an infection or pancreatitis can damage the lungs? How it can cause exudation of fluid, exudative phase, hyaline membrane phase. Cyanosis, diffuse crackles and hypoxemia, classical hallmarks. Must do partial pressure of oxygen and FiO2 calculation ratio by ABGs. Berlin criteria for the diagnosis of ARDS must be fulfilled. A simple mnemonic to remember that. If there is high pulmonary capillary wedge pressure, it is likely that patient is having heart failure decompensation rather than ARDS. In clinical practice, there can be features of both, and there can be an overlap between those conditions if the patient is also having congestive heart failure. Findings that can help you differentiate between ARDS and CHF: decompensation, bat wing sign, management, shift the patient to ICU, address hypoxemia, start the patient on vent. If the patient is having mild ARDS, start patient on NRM mask, use lung protective mechanisms. Prone positioning is very important in these patients to prevent atelectasis. Consider furosemide, and corticosteroids have an off-label use and can be used. In severe ARDS, rescue therapy is done. And then prognosis: mortality can be 30 to 50% in patients with multi-organ failure. If you liked my video, please make sure to click the subscribe button and make sure to follow us on Instagram. Thank you very much.